So, Stefan, so you can have your half an hour.
Thanks a lot. Thanks a lot for the very nice words, and I'm really glad to be able to be here in this very nice conference and nice place. And I also would like to take the opportunity not only to thank for the invitation to be here, but also thank the organizers for, I think you have done, the group in Sao Carlos have done a very, very good job in facilitating this conference, I think. So I think they all earn an applause. So I think we should give them an applause now. Taking the opportunity as one of the last speakers here, so I thought that was in place to do that. So what I would do today is talk a little bit about various aspects of how we can do dosimetry for PDT. And I will take two examples of that, if I get this one to work. And one of the examples would be the work that we actually did here in Sao Carlos in Brazil. We haven't evaluated all the data, but I will discuss a little bit around it and see what we are planning to do. And then I will discuss a little bit of a project on prostate cancer treatment that we have been pursuing for quite some time now, and I will discuss and give some update on where we are on that project. But I will start with a more superficial assessment when we do superficial PDT and how we can deal with that. So I mean, PDT has been around for a long time and has been successful, very successful for many superficial treatments. But as soon as the tumor gets bigger, we have problem with the light penetration, and we have to go interstitial somehow in order to get the light deep down to the entire tumor volume. So this is really, light doesn't penetrate that deep, and how do we get around that? And one way would be to deliver the light inside the tumor by having interstitial light delivery. So the main motivation, I will now start with the first project that will be more the superficial part of it. So I will start there and say that, okay, we have develop a system that we would try to assess the absolute concentration of a photosensitizer in order to be able to measure the concentration of a photosensitizer prior to PDT, but also to see the photobleaching of it. So can we use that as a parameter to assess whether PDT is successful during the treatment? And in order to do that, we need to be able to do that online and in a robust manner. So the idea here would be to, sorry, wrong key. Well, this is rather weak. To work on the treatment control and diagnostics. I mean, you can use it both for diagnostic purposes to know the absolute concentration, but you can also do it for treatment control for PDT. And what we have tried to do is to use not a spectrometer with a laser excitation and get a fluorescent spectrum and then assess from that way, but we are trying to both measure the reflectance and diffuse and fluorescence. Reflectance and fluorescence at the same time, in order to try to calibrate for the tissue optical properties. So it's not only the fluorescence that we have, but we also have to cope with the attenuation of the light inside tissue. And then we do it with, oh, thank you, with too complex. Here we go. And then we do it with LEDs and photodetectors, single-point photodetectors. And I'm coming back a little bit to why we try to not use a spectrometer. That's not because we can't do that, but it's actually in order to get rid of the background light. Because we also need, in this situation, to be careful with operating light and room light and so on. So then we will try to extract the concentration of this. And we have some advantages here, but we get rid of the fluctuations of the LEDs, and we also can suppress ambient light, room light or operating surgical lamp, whatever we have. So what we have here is this 5-source unit. So we have 5 different wavelengths that we alternate. So one at a time will shine light to this fiber optical probe here that we get in contact with the tissue. We collect light in the center here, take it into this detection unit here where we split off the light by dichroic beam splitters to 5 different detectors at different wavelengths. So that provides us with a combination of 5 excitation sources and 5 detectors. So that is 25 channels. And by using these 25 channels in a good way, then we can actually assess both absorption, scattering, and fluorescence properties of this sample that we have down here. We take all that into a computer and analyze that. And the other idea with this that I said, we would like to get rid of the ambient light. This we can do by modulating this as quite high repetition rate and have some type of lock-in detection. So we measure both on and off all the time. And that means that we can subtract the background very efficiently at 1 kilohertz almost rep rate. So that provides us with a very good suppression of background light. And we can also, and we did a lot of studies in tissue optical phantoms, assess, so this was a tissue optical phantom with intralipid, water, and ink or blood. We used both of them here. Actually, since I used the blood sample here, I should also have said that here. And protoporphyrin concentration as a fluorophore. So what we then can show is that, okay, if we have different phantoms, we had about 270 phantoms or so, with different optical properties, different absorbers, different scatterers, or different fluorescence concentration. And as you can see, we can assess these concentrations rather good from these 25 measurements. So that's really, if you measure correctly, I mean, you have 25 channels, you should be able to assess 3 different parameters out of that. And we can easily do that, obviously, quite robustly, it seems. So then we took that to the clinic just to see, can we use this to measure optical properties and the fluorophore concentration. And this was just PDT clinical of BCC. And then we can plot the fluorescence. We scan across here the lesion and measure the fluorescence and reflectance at number of points here, number of positions. And here is the tumor, and it ends here, so we have outside the tumor as well, where we have normal skin. And we see before PDT, we have a high fluorescence signal. This would just be assessment of a fluorophore concentration. After the PDT, we have bleach away most of it, and before PDT, we have or before providing any ALA, we have absolutely nothing, obviously. So that seems to work fairly well. And then we did that for a number of patients. And then we plot, this is a busy slide, I apologize for that. But we have a cube here where we have absorption on one axis, scattering on one axis, and fluorophore concentration on one axis. And all the blue dots here will be these phantom measurements that we calibrated on. So we will have all of this data of the phantom. And then we assessed all the clinical data that we had to see where do they fit on this. And all the red labels here will be lesion, and the green one will be normal tissue. And you see that, okay, we can have a tendency that we have more blood in the lesion than we have in the normal skin. We have higher concentration of the fluorophore in the lesion than we have in the normal skin. And also scattering, you can see that scattering doesn't vary too much. We have 2-dimensional plots here showing the same data as here, but just for you to see when we have take it down to one axis. And then we actually try to use multivariate analysis to see, can we use this data to see all these positions that we measure? Are they lesions or non-lesions? And with this information, actually we didn't miss a single point. All the points were correctly characterized with this. So this seems to work quite nicely, that we have this rather simple system with LEDs, APD detectors, and that we modulate them so we get rid of any ambient light. And then we can assess this quite nicely. So then we actually brought that system here to Brazil to do some mice studies. And we have a quick protocol overview. This data is not finished. We haven't analyzed this completely, so I would just show you some what we did. We had a number of mice, but we had a tumor of the hind limb. We used chlorine E6 as a photosensitizer. We treated them with PDT, changed the fluence and fluence rate. We did histopathology afterward to assess them. We did fluorescence microscopy, and we did this in vivo measurements during, before, and after PDT, so that we could assess this fluorophore concentration. And this is just one set of data that we have from one of the mice. So this is also, I should get my own. So anyway, the green curve here shows before PDT, and then we see the photobleaching as it goes, comes on along. And these are just some pictures from the lab where we see Lilian and RFA working. We see some mice, and we measure them at different colors, as you can see, that we have blue and red light here. And here when we're doing PDT to the upper right corner. So now let's get down to the second part of the talk. That would be prostate PDT. So prostate is a solid organ. It has, men have a lot of cancers or in prostate, so it's a very common type of cancer. We have a number of different techniques to treat that, but maybe there is a room for another treatment modality, and that could be interstitial PDT. And this is what we are trying to look into, if we can do that. And to do that PDT as well as we can, we would like to individualize it. So we would like to do monitoring during PDT, not only to do a treatment plan and treat and see what happened, but actually trying to monitor as much as we can during the treatment. And to do that, we use the optics, since we're using optical fibers already. So just quickly overview of this. We do some treatment planning. We administer the photosensitizer, insert the fibers, and do the treatment. Thanks a lot. So that is roughly the plan. And just to go into a little bit more detail, we first take ultrasound investigation, and then we're trying to find out where is the prostate, what is the region that we would like to ablate, and that we're doing in this tissue in this planning. And you take this imaging with transrectal ultrasound. You take different slices here, look at each slice, and line out where the prostate would be. And from that, all of these slices, you get a volume like this. And then the next question is, how do I plan to place the fibers? Since I can't really treat with only one fiber, I need multiple fibers. And where do I place them optimally to treat the entire volume as quickly, efficiently, as evenly as possible? So that's the next step to do that, to calculate these positions. And then in optimizing that, you get a number of positions like this, where you aim to place these fibers. And you do that very similar to brachytherapy, so the same type of template that you're using, trying to place the fibers there as accurately as you can according to these positions, and then you do some treatment planning. Now you measure again where you have them with ultrasound, and now you have to recalculate exactly how you should treat them optimally. But in order to do that, when you do the original treatment planning, you just use optical properties that you thought was common for any prostate. But now we actually have so many fibers in here, so we can actually assess these properties by doing some measurements. We send light in one fiber only to start with, and measure with a number of fibers here, take them out, and measure how much light do we have. What is the fluence rate? We need light in order to do PDT. We need photosensitizer in order to do PDT. So we can assess the concentration, as just mentioned. We can get that concentration. And we can also get how much oxygen you have, or how much oxygen is bound to hemoglobin. So you can measure the oxyhemoglobin content by doing spectroscopy here. All optical measurements, quite simple, using diffuse reflectance or diffuse transmittance, whatever you would call it, between fibers here. And then you do that for all the fibers. We have 18 fibers here, so you do a number of measurements. It takes a minute or two, and then you get all these properties. And then you redo the dosimetry here, do the calculation again. How long should I treat with all the fibers in order to treat the entire volume here? And then you start treating, and then you're repeating. After a while, you're stopping. Now you have treated a little while, so these red blobs would be what the volume that you have eradicated, ablated with a PDT at that time point. But then you're going back, stopping, doing some more monitoring, seeing if you're photobleaching, how quickly you're photobleaching the dye, if you have any changes in oxyhemoglobin and light penetration and so on, and updating the dosimetry. And then you're continuing here, doing that a number of times until you think that you're done and have treated the entire volume without treating the organs at risk next door, nearby. So this is a system with 18 fibers that we have, 250 milliwatts per fiber that we can deliver. And we have this optical switch we can turn on and off and do the measurements in between. We have a treatment planning that we have developed to do that. And this is a CE-marked system for Foscan right now. So this is again an overview of the entire procedure. The patient comes, we place them, we do this ultrasound, and then you do the contouring, you're placing the fibers, and then you're delivering the light. The light delivery usually takes 15 minutes to an hour, depending on the size of the prostate. We have done a very first clinical trial with 4 patients. So that was done in Sweden, in Stockholm and in Malmö. And it was primary early stage tumors. And we delivered intentionally very low dose, just to see that it was safe to deliver the light with this technique, not really aiming at curing these patients. So 4 patients were treated, and we did a lot of dose histograms, dose maps and dose volume histograms, and all of that planning. We measured the PSA before and after to see what happened, and it actually seemed to decrease quite a bit for these patients. We measured MR before and after to see what happened, and you can see something happened after PDT. We did biopsies so we could see what happened, and actually one of them turned out to be cured. There was no malignant cells left after 6 months. But the other 3 patients, we had still malignant cells. But it was not really intended to be curative. So the results would be that, yes, the performance of the dosimetry seemed to work quite nicely. As I said, we set the limits very conservatively. It was very well tolerated by the patients. The only side effect that we had was skin photosensitivity that we could already count on beforehand. So one of the 4 patients actually came out without any cancer afterwards. The other 3 patients were treated with other modalities. So the conclusion is that it seems to work. The light dose was set very low, conservatively, and still one of the patients came out without any tumor. So right now, what we are aiming to do, and this is really the update here, is that, okay, we're planning to do the next phase 1/2 dose escalation study to see how it's working. But not only that it's safe, but it's also, it seems to work okay. We have approval to do that. We are trying to secure funding, and we hope, and this is what I really hope, that we will be able to start within 6 months to do this, so that we can go on and do this. And this is just the people have been doing all this work in Lund. So the group I'm working with is Sune and Katarina Svanberg are both emeritus at the moment, mostly working in China. Johan Axels is very important for this work, as many of the other people around here. Arefe was the one coming with me to Sao Carlos. And of course, I would like to thank the people here in Brazil as well. So here is just, Yes, I didn't have a photo of you, so I took your car. Sorry. And this is the luggage that we came with, so that's quite nice. So with that, I would like to thank you, and this is the view from my hotel this morning. Thanks a lot.
Okay, we can have a few questions. Okay.
Thank you. Very interesting talk. For the patient treated for the prostate cancer, do they have to undergo anesthesia?
Yes.
And what kind of anesthesia? General anesthesia
Yes,
or local?
they underwent general anesthesia.
Any more questions? Oh.
Thanks very much. I was just curious why you started with such a low dose, because there is previous literature on this where much higher doses have been used. So surely you'd have cut out 6 to 9 months of dose escalation.
Now, this is, I fully agree. I mean, this was set just in order to get the approval to do this first study. They wanted us to do this small number of patients with a low dose just to see that the instrument was safe. But
The prostate gland of different patient varies considerably, depending on the tumor size and so on. How do you design that 18 needles or the number of needles for the different patients?
yeah, now this is a very good question, of course. And we have to design a system that works in most cases. And we figured out that, okay, the sizes vary between this, and then with 18 fibers, we would be able to treat the entire prostate within less than an hour. So this was basically the concern that we had. But it all depends on the photosensitizer concentration, and all of that. So in this dose escalating study, it's not for sure that we're going to use Foscan even. So it may be that we're changing drug. But I think we're going to stay with the 18 fibers because that's how the system is designed right now.
Okay, so before thanks again, Stefan, for the nice talk. Every plenary is being recorded and will be in the homepage. So if any of the speakers do not want to have their talks linked in the homepage of the IPA, should tell us now. Otherwise, will be for the word. Okay, so Stefan, thank you very much. Very nice talk.
Thank you.